Go ahead, Claire.
Thanks, Elizabeth. Welcome, everybody. Good morning. And welcome back to another week of CNA, the Canadian Nurses Association webinar series called Coffee with Claire. For those of you who are new this week, my name is Claire Betker, and I'm the president of the Canadian Nurses Association and a long-standing registered nurse in Manitoba. I'm speaking to you from my home in Winnipeg, where I have the pleasure of working, or the privilege actually, of working remotely as the scientific director for the National Collaborating Centre for Determinants of Health, which is hosted by St. FX University in Antigonish, Nova Scotia. I'd like to begin by acknowledging the land on which I live. I am speaking today from Treaty 1 territory, the traditional territory of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. We decided at the Canadian Nurses Association to start this webinar series almost 2 months ago now, to give us at the Canadian Nurses Association an opportunity to connect with our members, nurses from across Canada, on issues that were important to them, to you, related to the COVID-19 pandemic. Today's discussion, we're going to focus on interdisciplinary perspectives and shared or common priorities as they relate to COVID-19. And the topics that we've covered over these last number of weeks came from you. So I'm going to encourage you to continue to give us those ideas via the chat box or via the Q&A box and questions that you might like us to answer. I'm joined today by 3 guests who represent their profession or their discipline. And I'm going to start by asking each of our esteemed guests to briefly introduce themselves. And while I do that, I'm going to encourage you to use the chat box that you can find by hovering at the bottom of your screen where it says chat. So please introduce yourself, where you're from, who you are, and I'm going to ask our guests to introduce themselves. I'm going to start with Jan. Jan Christianson-Wood is the president of the Canadian Association of Social Workers. Jan? You need to come off of mute.
Okay, sorry. There I am. Okay, thank you very much, Claire, and thank you for the invitation to participate and to meet participants today. Very much appreciated. As you said, I am the president of CASW. I'm also the president of the North American region for the International Federation of Social Workers. I am a retired social worker, so I am working from home in the guest bedroom. I've worked with Child and Family Services. I was the first social worker employed by the Office of the Chief Medical Examiner in Manitoba as a special investigator. And I've worked in government services in various areas. Let's see, I represent a federation of partners with over 20,000 member social workers. We work through an intersectoral table of social work educators, regulators, and our federation partners. And as I said, we participate internationally with the International Federation of Social Workers, and we are involved in a lot of alliances of like-minded organizations.
Thank you, Jan. So maybe we've worked together here in Manitoba.
Very likely. I'm in Winnipeg. Yeah, very likely.
It's a small world and a small country. And what's interesting is the Canadian Nurses Association is a member of the International Council of Nurses, which has over 130 members, National Nursing Association. So very similar kinds of structures.
Right.
Thank you. Yeah, thank you for that. Great to have you here. So next we have Dr. Sandy Buchman, who's the president of the Canadian Medical Association. Sandy?
Yeah, thank you, Claire. And again, I really appreciate the opportunity to be here, part of an interprofessional panel with all my colleagues. We should be doing more of these, so thank you for putting this all together. So yes, I'm Sandy Buchman. I'm from Toronto. I'm a palliative care physician. I really focus on home-based care and palliative care for the homeless in inner city Toronto. As As president of the Canadian Medical Association, which represents over 70,000 physicians in Canada, I like to always keep in mind our vision, and our vision is for a vibrant profession and a healthy population. So I kind of look through that lens as we'll talk further about some of the challenges and opportunities in relation to the pandemic and how we can work together to address some of these things, perhaps in reinventing our healthcare system. The pandemic has revealed a lot of gaps and weaknesses in our healthcare system that I think need addressing. And I strongly believe it's through joint advocacy, working as interprofessionals at this level, at sort of a system level, in addition to working at the patient level and community level. We need to also be able to advocate at the system level together. We're stronger with one voice.
Thank you. And throughout my term as president is almost over. I have about 1 month left. And as I started out, we used the hashtag Stronger Together because that's what the previous president had been using. And Sandy, I couldn't agree with you more that those multiple systems levels and really being able to speak with a common voice. We are stronger together. And Sandy, you and I have had a number of opportunities this week to be beside each other, either on CBC last night or in front of the Senate the day before. And we do have a lot of common ground. So I look forward to that opportunity. Thank you. And finally, we have Shelita Dattani, who's the Director of Practice Development and Knowledge Translation at the Canadian Pharmacists Association. So welcome, Shelita.
Thanks so much, Claire, and thanks for having me today. And I echo what my colleagues have said already. It's a pleasure to talk to a group of nurses. I am just a little bit about my background. I'm a practicing pharmacist and have actually spent most of my career in acute care. I started out as an ICU pharmacist, so I've worked alongside nurses for 20 years and see the tremendous value in working together at the bedside and now at different levels of advocacy of the healthcare system and in presenting in front of various groups and panels. And it's my pleasure to talk to nurses, and I really understand and appreciate that you are the true, I think, unsung heroes of healthcare. So it's wonderful to be here with you today. I am here representing the Canadian Pharmacists Association, and I'm the Director of Practice Development. So I lead our professional affairs group, and we represent Canada's almost now 43,000 pharmacists across the country in over 10,000 pharmacies across the country. Predominantly, our membership is comprised, well, we have a federated model, so our members are provincial associations, but through them, our members are predominantly community-based or primary care focused pharmacists, although I think I speak from a personal lens from an acute care basis as well. We are here to help pharmacists and support them in delivering patient and person-centered care as part of an important circle of care comprised of the colleagues that are here with us today and others. So it's my pleasure to be here, and I agree with Sandy that I think we should have many more discussions about how we can be stronger together as disciplines.
Thank you so much, Shelita, and thanks to all three of you for taking time out of your very busy schedules to join us for this important conversation. So like previous sessions of Coffee with Claire, I'll pose a question to each of our guests. Following this, there'll be an opportunity for you to ask questions. And if we don't get to your question today, don't worry, we will answer them. Staff will answer them. They'll compile the questions and identify themes, and we'll provide relevant answers on our frequently asked question page found on our website, CNA's website, where there's a lot of really great resources and a lot of very important links to other organizations with lots of guidance for us around the COVID-19, both response and recovery. You can enter your questions today into the Q&A box, as I said, at the bottom. If you hover your cursor there, you'll see Q&A, which we will try to address today as many questions as time allows. It seems like it only gives us time for one question in there, but please ask your questions and we'll make sure we get the answers there. Our team at the Canadian Nurses Association, Carrie Shoehandler, Elizabeth Moran, and Josette Roussel are online here with me to help with the operations, and they'll be busily posting resources in that chat box for you, and we'll send them to you in a post-webinar email. The discussion today will be in English. However, we are joined by Josette Roussel, who is the executive advisor at CNA, who is able to answer questions in French. And I'd just like to ask Josette to say a few words right now. Josette?
Merci Claire. Bonjour à tous. Alors, on peut répondre à vos questions en français. N'hésitez pas à mettre vos questions dans la boîte Q&A qui est en bas de votre écran et ça nous fera plaisir de répondre aux questions. Merci beaucoup Claire. Over to you.
Yeah, thank you, Josette, and thank you for being here with us today. So, in a few short months, COVID-19 has had a staggering effect on our health system, our economy, and on our lives, forcing essentially a countrywide and global shutdown. In response, the Canadian Nurses Association shifted our focus to provide our members with needed support to respond to the pandemic, of which these conversations are part of it. Healthcare professionals across the board have faced concerns about appropriate personal protective equipment, PPE, and supplies, and the accompanying ethical dilemmas. Increased or changed workload and an uncertain working environment has impacted both their mental and physical well-being. And we've witnessed devastating impacts of COVID-19 on vulnerable populations, such as people living in long-term care facilities, those who are homeless, or in shelters, and of course, Indigenous communities. Interprofessional collaboration and support has never been more important, and that standing shoulder to shoulder or really working together and stronger together. So each of you, the guest here today, represents your professional association, and we're very interested to hear as nurses. I'm just going to check here. We have close to 100 online with us today. Very interested to hear about the challenges your members have been facing and opportunities that have been created. And I anticipate we'll hear some very, very strong areas for collaboration. So I have a question. We pre-meet with our guests prior to these sessions, and so we agree in advance what those questions would be. And as I said, they're informed by your feedback to us. So keep talking to us, those of you who are online and with us today, in the chat box. So I'm going to ask each of our guests to tell us just a bit about the organization. They kind of did that in their introductions, just to set that stage for us. And then to highlight what the challenges related to the COVID-19 response, but also the recovery that they're hearing from their members. So what are you hearing from your members? And what are some of the key opportunities that this most unprecedented situation has created either for your organization or for us together? And I'm going to ask Shelita to go first. And so go ahead, Shelita.
Thanks, Claire. Thanks for unmuting me. So as I mentioned earlier, at CPHA, we represent Canada's over 42,000 pharmacists across the country. And in times like this, and in times of national emergency like this, pharmacies are considered essential services, which means they have to stay open and accessible when others are closed. And this pandemic hasn't been an exception. So pharmacists have certainly adapted considerably to continue to serve their patients. Either through their brick and mortar pharmacies where they stay open, and even virtually and through deliveries in providing access to medications and continuing to provide medication management. We surveyed our pharmacists now about a month ago, similar to each of you who have also done surveys of your membership. We did something as well, and what we learned from that survey was really sort of reinforcing for us in terms of what we speculated as some of the major concerns of our profession. And the top four issues that pharmacists are, and I would say continue to be concerned about, and I'll speak to some of the recovery pieces as well. The first one was really the safety of themselves and of their pharmacy staff and of the patients that they serve. So over 60% of pharmacists in our survey were concerned about safety as they want to continue to stay open to serve their patients. They do recognize that without appropriate access to personal protective equipment, they are vulnerable themselves, their patients are vulnerable, the families that they go home to are vulnerable. And I love Sandy's analogy about sending someone into a burning building. I think we all have that same concern. And as we move into a recovery phase and as the country starts to reopen its doors, I think that concern is amplified in terms of being able to provide the care. Their pharmacies are very dynamic environments where we want to be able to help whoever is coming in through the door, and they're not appointment-based environments. So sometimes those interactions can be very unanticipated, and the ability to protect your staff and your patients becomes paramount. I think also looking forward to the flu season, I think that's another sort of area of concern in terms of continuing to want to immunize patients. And I suspect all of us will have the same concerns as providers of influenza and other vaccines, that we want to make sure that we're dealing with appropriately with what I think are probably going to be surges in demand for influenza, as we're learning from our colleagues in the Southern Hemisphere. But again, protecting ourselves and our patients as we continue to help with preventative health care. The second biggest concern from our survey was related to drug shortages. And I think early on in the pandemic, in February and March, we saw people clamoring for toilet paper. And we saw toilet paper flying off the shelves. And not unlike toilet paper, medication quickly became the new toilet paper. And people started stockpiling in fear that they wouldn't be able to access their medication. We already have a drug shortage problem in this country. We have a global drug shortage problem. And we had some concerns about that compounding as well, and we've done some work in that area. But drug shortages continue to be a concern for us. I think although our supply is stabilizing, we need to carefully manage what happens in the incoming months. Just like we go into a recovery phase with COVID, we also need to understand what's going to happen to our drug supply and how we can ensure that Canadians receive the medications that they need. The third biggest consideration was workload and staffing shortages. I think like everyone, staff are just stressed, they're anxious. It sort of correlates with the fourth biggest concern, which is mental health and burnout. Although pharmacists want and are very grateful to be able to serve patients every day, you know, there's been a lot, whether it's explaining a 30-day medication supply to a patient, or helping a patient with their COVID symptoms, or delivering medications to patients. There's a tremendous amount of workload, and there are just supporting frontline healthcare providers through their mental health challenges is, I think, something that we want to do. Would you like me to move to maybe an opportunity, Claire, now? So I think those are some of the challenges. I think some of the opportunities that this has unearthed for us through COVID is for pharmacists. I think we see ourselves as public health stewards, and I know, Claire, you have a background in public health, and Sandy and others. I think we all have a responsibility to preventative care of the Canadians that we serve. But pharmacists through this crisis have really been providing a tremendous, education role, a coaching role. They are immunizers. There is talk about what will happen when a COVID vaccine comes out and the role of pharmacists. And I think they see themselves, because they're so accessible in every community across the country, as being stewards of public health. So I think that's wonderful. And I think, again, as being all stronger together and working as a village to protect patients and their public health, pharmacists are stand with our other professions there to help patients. I think the second, and just briefly say, the second sort of opportunity is we've had some in pharmacy, particularly related to opioids, some relaxation of regulations in that we can help some of those vulnerable populations that we talked about and ensure that they have the continuity of care that they need if they need their opioid medication delivered, or their therapy extended, or their dosage adapted, in collaboration with other healthcare providers, but giving pharmacists the opportunity to leverage the important relationships they have with their patients, so that they're not left at any point in a situation where they're vulnerable to not being able to get continuity of that care. So those are two opportunities that we've that I think we've identified. Thank you.
Thank you so much. And I think those are really, really two very, very interesting opportunities that I think we'll hear from the others have come. And, we really need to make sure that we don't go back on some of this, right? That we actually continue to move forward. One of my colleagues said, we want to go back to better, not back to what it was. So I think both of those opportunities, Shelita, are are incredible things that we need to keep moving forward on together. Okay, Sandy, I'm going to ask you the same question then about the challenges and some of the opportunities. So over to you, Sandy.
Great. Well, thanks again for this opportunity to be able to share the perspective of the members of the Canadian Medical Association. Like I said, we're 70,000 plus strong. And this pandemic has really revealed so many of the difficulties, not only the current challenges that we're facing, but have revealed the gaps in the system, the weaknesses that we have. So I'll review them like that. We did surveys of our membership, both at the end of March and in about the third week of April. We got the most robust response, at least over 5,000 response to the surveys, which for doctors was very good. In particular, they brought up the issue of insufficient and substandard personal protective equipment, similar to what Shelita said. Their doctors were unaware of what personal protective equipment was coming down the pipelines. The community-based physicians stated some only, about 30% only had 1 or 2 days supply of personal protective equipment. This was creating immense anxiety virtually for everyone. And that is on top, as is mentioned earlier, of the long-standing issues of burnout and the stress of being in a situation with COVID. And they were experiencing moral distress. They were not only worried about their own health, but of course they were worried about transmitting the disease to their patients and bringing it home with them. Many doctors were experiencing significant challenges with not being able to interact with their family and loved ones. They were living elsewhere. They were staying in their garages. And I know this is true for nurses and other health professionals as well. But the mental health issues were paramount, and there is concern about long-term mental health issues once this first wave is over, because we're in a marathon. So further depression down the line, possibility of substance use disorders, PTSD, that kind of thing. There was a lot of concern about the shortage of medication. Shelita has referred to it, but it's been from propofol to salbutamol. These things were great concern. Insufficient testing. So there is a constant concern that we have inadequate information to make evidence-based decisions about reopening our economy, our businesses, our schools, our hospitals. They felt that we need further testing, not only a random testing, but those who are asymptomatic, those with mild symptoms, high-risk occupations like healthcare providers, of course, transit drivers, truckers, grocery store clerks. We need to get better ideas of what the prevalence is in the community, where it is, so that we can do the contact tracing. We have inadequate contact tracing. We won't be able to identify those people who are exposed and then put the restrictions. This is our way out. Physicians are reporting, especially in Ontario and Quebec, the risk of losing their practices. That patients aren't coming in, they're fearing of coming in, they can't afford to maintain their practices, they're concerned about their staff and their employment. And so this is a grave concern out there. There's huge concerns that the ongoing care of patients has been deferred. Not only the surgeries that are becoming more urgent and emergent, but they're concerned about the chronic disease management. They're concerned about their patients who have diabetes and asthma and COPD and heart disease not getting managed. We're already seeing a decrease in childhood immunizations. So the consequences of these are quite broad. And finally, I just might, without going into it, is the tragedy that happened in long-term care, and the approximately 80% of deaths in this country have been in long-term care. And it's just not the biological vulnerability of our citizens, it's the system issues, it's the underfunding, and it's the understaffing and the infrastructure. So it's a huge area, and these are where doctors are concerned. So that naturally brings us to an opportunities, and I like to view the pandemic through that opportunity lens as well, because in some cases there's a silver lining. And in particular, it speaks to what I believe our obligation is as healthcare professionals, and that's our social accountability. We have a mandate. We are privileged, we are lucky. And what's our mandate to pay back and improve the system, to advocate not only for the individual patient, but what we can do at the system, kind of a micro level at the individual patient, the meso level at a community, what we can provide, and the macro level at the system issues, which are where our associations work. And there are several things, of course. We ignored pandemic planning from the SARS Commission, which came out about 2006. It was prescient about what we could do. We need to get back to that. But in the meantime, we have to advocate for scaling up testing and contact tracing, as I referred to before. We have to bring on virtual care. It's exploded right now in terms of what's happened. We've come out with a task force report in February outlining the governance and regulation, the policy, the safety about virtual care. The technology has always been there. So we need to reinvent the healthcare system with virtual care. In addition, we have to look at interprofessional models of care to accomplish this. And we have to break down walls, and there are many good examples of innovative interprofessional models that will improve the access to care issues from primary care to remote and rural. And ultimately, as I mentioned earlier, we need a complete reopening of and discussion, national conversation about long-term care. It's been the poor cousin of the acute care system designed in the 60s for a younger population with acute needs. And so that takes a national conversation, maybe even opening up something like the Canada Health Act. I'll leave it there, and thanks for the chance to speak to a very complex question.
Yes, and thanks also for bringing that social mandate into the room and into this conversation with us, because I know for us at the Canadian Nurses Association and for our members as nurses, it is a social mandate. It is a relationship with our public at all of those levels. So thanks for bringing that in there, Sandy, and those are really important opportunities that you've highlighted, as well as issues. So Jan, we look forward to your perspective then from a social workers' perspective. So over to you, Jan.
Thank you. I'd just like to comment first that this is a unique experience to sit with this group, because we all serve Canadians in crisis, and we are all focused on partnership to improve the well-being of Canadians. And you know, as Dr. Buchman has said, this is an opportunity as well as a crisis. We have social workers who are working through the pandemic. That's not always generally known. The Child and Family Service, or the child protection workers, often are working without personal protective equipment or a very limited access to it. They are not able to get out to see families, which causes great worry about, and there's been a fair amount in the news media about an expectation that there has been child abuse or child neglect happening, and it's just not being discovered. And regular caseloads that were monitored closely, workers have not been able to see them face to face. We also know that the social workers in mental health are also concerned about access to their clients. Our private and clinical therapists are moving to telephone and internet work, which again is, you know, for all of us, is not our preferred mode of working with people. We have people who are working in EAP, people who are still practicing in education. We all have the same needs for masks. We all have the same needs for testing and worry about exposing ourselves and our families. I was very happy to hear the comment about long-term care. This has been a particular concern of mine over the years, in that we don't provide quality long-term care based on what's required of provincial authorities in terms of what is defined as quality care. Opportunities, well, this is a terrific opportunity. We are all experiencing similar concerns, and we all have similar goals. We want to improve social well-being of Canadians. For the CASW, we're looking at proposals for a Social Care Act, so Canadians have an entitlement in law, and again, based on the social determinants of health. Again, we have social justice aims and goals, and one of the things that we would really like to see would be, and I've heard it here, income support so that all Canadians have a guaranteed income that cannot be clawed back by the province. So for those of us who may not need it, it would be, we would pay through a progressive tax system, I imagine. But for people who this is supplementing an income that is barely at a living wage, there would not be a clawback, that this would be used to improve their well-being. Our outcomes, we hope that we'll continue to work together. We are very worried, as are you, about our members, about the people who work in child welfare, what they're going to find when things open up, about the workers who work in domestic violence shelters and in counseling and in community shelters, about what's going to be the outcome of this with the increased mental health burden. The opportunities, well, the opportunities are that we will work even more closely together than we do, and that we can advocate together for better primary care, for a better guaranteed income, for planning. As Dr. Buchman has said, let's really engage in planning for the surge, because if it happens as we expect, it would be much better if we knew going in what we needed to do for the people we serve and what we needed to do for our own members to keep them healthy. We are expecting, as Dr. Buchman has said, to see an uptake in anxiety disorders for our own members, possibly PTSD, and then they will in addition be dealing with people who are experiencing those conditions as well. But this offers opportunities for joint advocacy, and I think that we can do a lot working together. Thank you. Thank you very much.
Thank you, Jan. And again, a wide-ranging, so if you put all three of those perspectives of opportunities together, you have an incredible set of very unique opportunities, both right now, but also as we move along. One of the questions in the Q&A is around home care, and we were talking about long-term care. In my head, home care is part of that set of services, but there are many, many people who are vulnerable, who are in receipt of home care. It is a system that is not consistent across the country. And so I'm wondering if that might be an area where we have a few minutes here for questions. If each of us or each of you could sort of take a very sort of pointed look at that particular sector of our health system. And of course, home care is not just about our senior members, right? The home care system is set up for people with other types of disabilities, people who need supports to remain independent in the community. So I think I might start with you, Jan. You were just kind of right there in terms of talking about home care. And then I'll go to you, Shelita, and then finally to Sandy. So, and Sandy, I know that's part of the work that you do right now in terms of care at home and palliative care at home. Jan, to you.
We know that home care is an overburdened system. We know, as you said, that it's not equitable across the country. People who work with home care workers, nurses, social workers, health aides, know that there is a huge shortage. And that people are managing caseloads that are much, much too big. Families who have the opportunity to plan their own home care find pretty quickly that it's really hard to do, to find those people, to have them consistently employed, to have enough people to have coverage, and also to advocate through the system to have enough coverage for instance, if you're caring for a younger family member who has severe Parkinson's, you need round-the-clock care in order to get sleep yourself, to continue to work, and to continue to manage your home and family while that family member gets the quality care that they need. So home care does need to be scaled up, and it needs to be participatory for those people who wish that, but we also need to provide management supports for people who would rather have a system managed approach. Thank you.
Thanks, Jan, and thanks for that important question. Shelita, and then to you, Sandy.
Yeah, I would agree with Jan and you, Claire, that it's an area that is has tremendous need and is tremendously under-resourced. And I think speaking specifically to the role of pharmacists, and I guess taking a page from my previous role in acute care, I think particularly when patients have transitions in care, they leave the hospital, they go to home or back, I think those are very, very vulnerable times for patients. And I think the complexities with medication management, and we know that particularly in some populations, in some comorbid states, medication-related complications will often land people right back in the hospital, for example. So I think that the ability of, in that space, again, to work in an interdisciplinary fashion, but to utilize the role of pharmacists specifically to help with medication stewardship to ensure that they can help contribute to helping patients stay at home safely and get the needs that they can, so that we're not overburdening our acute care system again with these patients who and people who would like to stay in their homes.
Thank you, Shelita. And I did in my career about 10 years in home care in rural Manitoba. And of course, the pharmacist was a community member. We knew him and her, and they were part of our team, and a very, very important part of our team, and a very, very important part of the person who was receiving supports team, right? Because it's really about them and their family, and that's the patient or the person-centered care. And so we really appreciated the input and the care of the pharmacist. So Sandy, to you in terms of home care and what might, in terms of that long-term care, but home care in particular.
Yeah, I thank the registrant who submitted the question, because it's a key one and it's a key opportunity. I've been doing home care for the last 15 years, obviously through palliative care, but we have a lot of experience in palliative care in providing home-based care, and as I might add, care for the homeless as well, the more structurally vulnerable, because that's a continuum from the street to couch surfing, as people well realize. It is the prime example of interprofessional care. I can't even conceive of practicing my area of medicine or doing anything without the interdependency and the supports of the professionals from social work, nursing, nurse practitioners, pharmacists, OT, PT, you name it. We have it and it works. It is patient and family centric. Family members and patients are true partners as caregivers in care. And particularly if we had more home care now in terms of the COVID, we could be looking after these patients, many of them at home. And if we actually included things like advanced care planning and goals of care discussions, we could very well do that at home. It's cost effective to have home care. We have lots of evidence that it decreases emergency room and hospital admissions. We don't need to put as much money into bricks and mortar facilities for long-term care, because we could put that money into nursing care, personal support worker care, etc., all in the home environment. We could improve the wages of these workers, and they could thrive much better. And that's where a lot of money should go. We will still need some upgraded facilities, that's for sure, but we can do a lot more at home. So I also think it's a fantastic opportunity for virtual care. When you can provide virtual care in the home environment, patients appreciate it so much. Their family members do. They don't have to take on the expenses of travel, of parking, of transportation. All that is gone. People, they're say middle-aged children don't have to take work off for the day to make a visit to a hospital. So I think it's really an opportunity whose time has come, and it's one of the solutions to some of the things we're facing in this crisis.
Thanks, Sandy, and thanks for speaking so passionately from that sort of day-to-day experience that you're having right now. And it is something that would respond really well to a broad primary healthcare model, right? Where you would use those principles of primary healthcare that were just reestablished in the fall of 2018 by the World Health Organization. So I think lowest technology, involvement of the community, engagement of the people who would benefit, all of those things are really, really important principles. Okay, so we have a few minutes, I think, for one more question, and I think I'll take us back to focusing on our members. And there is a question here about what happened post-SARS. And it says that it's really important to plan for post-SARS pandemic strategies to address the emotional residue left with healthcare providers. And there's a history, and I would agree with this, a history of organizational patterns of just moving on or suppressing situations of high emotion. So what are some of the ways that you within your organization are thinking about that post-pandemic strategies to really be thinking about our members, those healthcare providers out there? And Shelita, I'm going to start with you and then go to Sandy and then to Jan.
Yeah, I mean, it's interesting, and I think we are starting to think. I think Jan and Sandy and you have already brought up, you know, a lot of things in terms of mental health, and both the mental health of the patients that we serve and the mental health of the professions through this and through a recovery, through a potential second wave, and then, you know, elements of, you know, even suggestive of PTSD and how we are going to come through this and support an already well described, I think I would say almost global phenomenon of healthcare provider burnout that we have all been talking about. Certainly we've been talking about through 2017 and 2018. I know CMA has as well, and you have as well. So I think thinking about that and how we're going to help the profession will be important. I'm not sure if this is really part of your question, but I think Sandy alluded to some of what I tried to call sort of through the CMA survey, some of the populations that may not be receiving the care they're receiving right now because we're so focused on the acute crisis. And so sort of what I like to call the casualties of COVID and some of those, you know, patients with chronic disease, et cetera. So as we move through this and beyond, again, we're trying to encourage pharmacists to continue to leverage their accessibility and their relationships with patients to even do things like, you know, if they're not immunizing patients themselves and they're not immunizing children, but they have those relationships with those parents to say, please don't delay those essential childhood immunizations that have to happen. Please make sure that you're not reticent about going to the emergency department if you have chest pain. Let me, you know, I can help you sort of make sure that your hypertension is being managed appropriately, or I can be a referral source to somebody else. So I think as we move through this and get beyond the acute phases, we're encouraging pharmacists to continue to leverage their role, and they are really standing up to action to make sure that they are continuing to serve all of the sort of particularly chronic disease issues of the patients that they see in their primary care environments that they work in.
So great, you answered that both from the members, right, the pharmacists themselves and what they're anticipating. Jan, what are your thoughts on supporting our members and our teams as we move forward in this?
Well, this is something that we have been concerned about. We've been working in a closed Facebook group to provide some peer support for social workers, and also, you know, as others have said, try to encourage people to come forward and ask for help or indicate that they would like help. We're not always, as helpers, good at advocating for ourselves or even accepting the help, thinking that, you know, it might be better used by somebody who is in a more critical condition. But yes, we are concerned about this. We think that social workers will be coming back having seen situations that they haven't experienced in their careers. So we are preparing for contact with our members to emphasize their own well-being, their own health, the health of their families. It's a reality that it's hard for people in the helping profession sometimes to do that reach out. So we'll be focusing on emphasizing personal care, well-being. We do webinars for our members as well that do talk about social issues, but also talk about issues of concern to the profession. And I'm sure that our members will reach out to other social workers, clinical social workers. They'll reach out to nurses and to doctors. Shelita, what you've said is really resonating with me, because I've taken for granted how much it means to be able to talk to a pharmacist and to have somebody say, you know, I think I'm going to call your doctor. I'm not so sure that you should be taking that right now. And having my doctor say, hey, I was glad to hear that message. So if working together as a group, I think we can also advocate for social action, but we can support our professions across professional lines, providing care to our members. Thank you.
Great, great. Sandy, I'm going to ask you to speak to your members, but there's a question that's come in on the chat line, in particular with this second wave. If you could just sort of, you know, think about next fall, the next few months. What are you thinking about as your association in terms of your members, particularly with the second wave, that I think we should anticipate?
Okay, well, thanks. I'm just going to comment on the first question because I think it's a really important question. You know, to address the emotional residue of healthcare providers, and I'll just say, you know, it's my demographic. I lived through SARS, and I think there has been some neglect of the emotional residue of doctors and nurses and other professionals who suffered through SARS. Many of my colleagues and good friends experienced that because we worked in Toronto, but so that it is there. It's very real, and it's real to this day. I have physician colleagues who were triggered by COVID. Based on their experience with SARS, and some who had SARS and actually survived it, they are very triggered. And I think we neglected it organizationally because it was localized in only certain pockets, like the Toronto area, and wasn't really. And then I think it's often normal human complacency. There were other important organizational health issues, you know, to address, and so many things move on, and it's kind of behind us. So I just think that's part of what we did, and it's really important to learn from that now. And so with regards to the second wave, you know, I've been asked in many of the interviews, will there be a second wave? And you know what, there's never been a pandemic in recorded history that did not have a second wave. And so it is inevitable, and it's a certainty, and it is usually worse. We at the CMA are talking about mitigating it. When the first wave came, we didn't have data, we didn't have information. All we knew is to impose physical distancing measures. Obviously hand hygiene, isolating at home, quarantine, social distancing, now the use of masks. Those are just the physical measures that work. But they were no different in a way than what happened in the 1918 flu pandemic. So now we have the ability with technology to gather the data. We need information to be able to reopen our schools and businesses and hospitals, et cetera, as I referred to earlier. And that is through increased testing for the asymptomatic and mildly symptomatic population, those high-risk occupations I mentioned earlier, putting that data together to make the evidence-informed decisions that will allow us to open up, because, again, as referred to, the consequences of not opening up are also very great. So every jurisdiction has to balance that. And so that's kind of where we are now. That's where you and I, Claire, presented that to the Senate and through our interviews. And that's where we're going to go. We're very delighted to see Trudeau, who has met with the premiers now, putting increased funding into that testing. Why it hasn't happened up to now, I'm not sure. It's a little better in Alberta and British Columbia, but I'm not sure why it hasn't happened in other regions.
Okay, great answer, Sandy. Thank you for that. So we're coming right down and out of time. And I'm going to finish off, we talked about having one final question, and I'm going to ask you for the top idea you have about some thoughts on joint advocacy or joint action. So it's fine to talk about what we have in common, but what could we actually concretely do together? And Jan, I'm going to start with you and then go to Shelita and then to Sandy. So Jan?
we see each other in alliances and in various organizational meetings. I think we could advocate for a Social Care Act to cover the gaps in the Canada Health Act, or fill in some of the gaps, and also to look at a guaranteed income for people who lack the wherewithal to do some of the things they need to do to stay healthy. So I think we can advocate together for those two things.
Thank you, Jan. And that was something that both Sandy and I did speak to the Senate about as well. And what comes to my mind is solidifying some of the policies that have been put in place. So really advocating for that action. Shelita, what about for you? What would be, and maybe in addition to what Jan said?
Sure, yeah, and I think there's a few that we've all already, there's a few common denominators that I've heard over the hour. I think for me, the issue that is sort of provider agnostic and kind of translates across all of us here on the panel and other frontline healthcare professionals is mental health, and protecting and supporting the mental health of the professions that we serve now in the next phase. And to Sandy's point, for potentially, a long time moving forward, because we will, it's really powerful, your words, Dr. Buchman, when you say there's never been a pandemic in history where there wasn't a second wave. So I think getting ahead of protecting, the mental health of our profession so that they can continue to care for their patients safely is something we could do well together. And there's more commonalities and there are differences there with all of us.
Thank you so much, Shelita. And I think that's a great area for advocacy and for being able to suggest and perhaps jointly implement some common action there as well. Because actually some of it is right within our own association's ability to do some things together. So thank you for that one. And Sandy, final word to you.
Well, I couldn't agree more with the choices that Shelita and Jan made, but I'm just going to put forward a third one. And that is, we should have joint advocacy about developing innovative interprofessional care models. It works, it's cost effective, and it's the best that we can do, bringing everybody's competencies and strengths to the care of the patient. It's about integration. We have great models. To give you an example, in primary care, the patient's medical home model is well established now. And when I advocate for this at the highest government levels with the Minister of Health and others, their ears open when I talk about its interprofessionalism and that people are supportive of interprofessional innovative models like that. So that's where I would put my vote today. I think that can do a lot to address many of the problems that we've seen through the pandemic that has exposed the weaknesses in our current system.
And I couldn't agree with you more. And it's really on those shoulders, right? Both the upstream shoulders of the health system and then the long-term care and those that are in the other parts of the health system. So that, and we do have models that work. And for those of us that have the gray hair and are long in the tooth, we've been part of those teams and seen really concrete impacts and outcomes as a result of those models of care. So we know what works. So I think if we could stand shoulder to shoulder on that and really do some joint advocacy, I would be most interested in that. And I know the Canadian Nurses Association would be as well. So thank you so much, the three of you, for agreeing to attend today and for your absolutely outstanding contributions to this conversation. So I'm just going to thank those of you that are online. There's still about 90 people online, so thank you for staying with us for a few minutes over. There's a poll that's up for you to answer right now about how likely you are to use this information. And I'd like to invite you back next week. We will have another conversation with Claire next Friday, same time, same place. And I look forward to seeing you then. So thank you, Shelita, thank you, Jan, and thank you, Sandy. And have a great weekend, and we'll see you next week. Thanks. Bye now.
Thank you. So long.
Yeah, bye-bye.